Hi, I'm Mark Plaster. I'm the executive editor of Emergency Physicians Monthly, and I'm here at the 2009 Scientific Assembly of the American College of Emergency Physicians with Chris Carpenter, who's chief clinical editor of Emergency Physicians Monthly, but also the publications director of Best Evidence in Emergency Medicine. Thanks.
Yes, that's
Chris,
correct, Mark. Thanks. Well, thanks for having me here.
And your specialty, actually, I wouldn't say specialty, but your area of interest has been in geriatrics.
Yes, Mark. I've been investigating geriatric aspects of emergency medicine for about 5 years.
And I don't want to sound ignorant here, but why should I care about it? I mean, obviously I care about all my patients, but why are geriatric patients, or how are geriatric patients different? What's so different about them?
Well, Mark, that's a great question. The geriatric patients are coming at us in numbers we've never seen in the history of mankind. If you looked at all the patients over the age of 65, just the population, just the patients over the age of 65 who have ever been alive in the history of mankind, half of them are alive today.
Wow.
And that number is going to increase in the next 30 years as the baby boomers become octogenarians.
Wow.
And we all know that in the emergency department, these patients are very difficult to manage, consume a lot of our resources, our time, our inpatient beds, our ICU beds, and right now they're overwhelming our emergency departments. In another 20 years, that number is going to be far worse. And so they're very complicated patients, and there are effective ways to manage them, but it requires a different model of thinking than the typical ED model.
And we also have the pressure now of trying to care for them and spend less.
Yes.
And the model of the whole insurance issue of reducing all of our costs.
Yeah, it's a perfect storm.
Yeah, that's exactly right. Well, give me some examples of areas that we should be concerned with and how it will change our practice.
Yeah, there's been some excellent descriptions of a geriatric emergency department, one that is friendly to the older patient, prevents iatrogenic injury, falls, infections. So for example, we know that about 35% of the patients that we see every day over the age of 65 in the ED have dementia or delirium. Okay. Of those, we'd hope we'd be picking those up, but we're not. We're missing about 70% of them that pass through our EDs, whether they're admitted or discharged.
We don't recognize that they're demented?
We don't recognize it. And that can be all stages of dementia, but the early stages of dementia, there's some that are treatable. About 10% of those are treatable. They have a reversible dementia. But more importantly, we have a chance to impact them at a point in time in their disease state when they can make decisions about end-of-life care, save money later on down the road, about what they want to do with their finances, with their family, spend quality time with their family when they're still capable of doing so. And from a medical legal standpoint, they may not be understanding anything that we're talking to them about in the emergency department, or at least not remembering it the next day when decisions are made.
That's kind of typical, isn't it? We talk to a patient and we think we've gotten the full history, and we haven't, because they are in the early stages of dementia. We think we've given them some sort of homegoing instructions, and they don't remember it. They don't remember it.
So a tree falls in the forest. Did it really fall? Nobody's there to hear it.
And maybe some decisions need to be made early on with family members that we need to pull them in and get them involved. So
a simple intervention that we've started in St. Louis is having medical students who have no other capability in the ED, no other responsibility, do screening for us using validated screening tools. And during sampling of hours in the ED, they screen these patients for dementia, delirium, fall risk, immunization deficiencies.
Give me an example of some of the screening questions. I mean, how do you screen somebody for a fall risk?
There's fall risk factors that have been validated. For instance, past falls. If somebody's got a history of a fall in the last 4 weeks or in the last year, they're about twofold more likely to fall in the next 3 months. And so they're more likely to fall in the next 3 months. So we have the capability to intervene on them, identify them as a high-risk fall, or find out what their fall risk factor is specifically, and hopefully prevent that fall from occurring. And you know the fall is a precipitant for a rapid decline thereafter.
Sure. Everybody knows the grandmother that fell in the bathroom, broke a leg or broke a hip, and died 6 months later.
Yeah, never recovered.
Never recovered. Yeah, that's exactly right. And you're right. It's not something that I ask all the time. Have you fallen?
Who has time?
In the last 6 months? Well, it would be simple enough to ask that question. Give me some other examples of things that we can do to stratify or identify the geriatric patient who's at risk.
Okay, we've developed some brief screening tools to identify dementia and delirium. One is called the CAM ICU, which will
CAM ICU?
The Confusion Assessment Method ICU, and that can be administered in 1 minute or less, no paper or pencil required. Yeah, that tells you if a patient's got delirium. You can risk stratify them for delirium, and they don't even need to be able to read or to speak. speak. They can nod or shake their head yes or no. We've got something called the 6-item screener.
Let's talk about the CAM ICU.
Yes.
Tell me a little bit more about it.
Okay.
Can you tell me what the questions are? Or
the questions involve, there's a series of 10 pictures that we show a patient, and we ask them, we're going to show you these pictures once, and then we're going to show them to you again, the same series of 10 in the same order. When you see the picture again, I want you to nod your head yes, that you've seen that before. And if they get more than 4 of those wrong, then they're at risk for inattention, and that's one of the components of delirium.
Sounds like my children.
Yes, or me after a long night shift. Yeah,
exactly. But I understand what you're saying. So basically, the short-term memory is just simply not there.
Right.
And it's a subtle indicator of short-term memory, which we sort of feel, but we don't have an actual method of measuring.
Yes, a defined metric that we can all employ in the same way every time helps us to identify these patients reliably.
Fascinating. Okay. So the CAM ICU, you were going on to something else.
Yeah, for dementia, there's something called the 6-item screener, which is basically
the 6-item screener.
Yeah, 6 questions.
I'm slowing you down so you don't speak so fast.
So the 6-item screener is 6 questions.
Okay.
To identify orientation of the patient. Do they know where they are, what they're doing there,
okay,
and what month it is? And then we ask them to remember 3 objects for 1 minute. Say apple, tree, baseball.
Right.
And say, I'm going to ask you to remember these for a minute. Please remember them. And then you come back and ask them a minute later for those 3 items. If they make 2 mistakes in either their orientation or their recall, then we've identified them as high risk for dementia.
Okay. So you've identified somebody as a high-risk patient. Mm-hmm. How does that change how you're going to treat them?
So what we have done in St. Louis is we've acted as an information conduit to community resources. We've got something called the MAPS program, the Memory and Aging Project satellite. So what the Memory and Aging Project allows us to do is go to the patient's home, assess their home setting. Is their home setting safe? Is there a big fall risk at their home? Do they have to go up and down stairs? Do they have?
And who handles that?
This is our geriatricians and our occupational therapists at Washington University. And there are similar resources available in every community through the American Alzheimer's Association.
Outstanding.
And many times these are free. So these aren't things that depend on your...
But these aren't actually agencies that the emergency department is generally used to dealing with.
Correct. And so what we do is we screen the patients and then act as an information conduit to those resources.
So even if they don't have something that requires them to be admitted to the hospital right now, you may be preventing them from being admitted at a later date because,
that's our hope,
because you've actually identified them as an at-risk patient.
Yes, that's our hope.
That's outstanding.
And we do know that those patients do tend to come back to the emergency department within 3 months, visit the ED, and many of them are admitted at that time.
That's right.
So we're saving hospital expenses both from the ED side and the inpatient side.
And you mentioned that you help families identify and get involved with planning. There's been a lot of discussion about mandated, with healthcare reform, with mandated discussions between physicians and patients and families concerning end-of-life decisions. How does this play in? It sounds like you're saying that when you identify an at-risk patient, maybe that's the time that it would be appropriate to step in.
Yeah, I think it's important to understand that our tools are simply screening tools, that we don't make a definitive diagnosis, but we say that this patient is at high risk for having dementia. And there's better testing that can firmly define that. Is this Alzheimer's dementia? Is this vascular dementia? And there's different treatments for both of those entities.
Where do you refer those patients? If you feel that the patient is at risk for dementia, where do you refer them to?
Generally, the neurologist will handle the definitive diagnostic testing, but the delay to that diagnostic testing can be 3 months. It can be several months later, which is not satisfactory, but that's the gold standard testing. But I do think that once the diagnosis is established, preferably outside the ED setting, we're trying to simply risk stratify them. But once that diagnosis is established, we can identify early stage patients who then can make their own decisions about when they get to terminal illnesses, what they would want done, rather than waiting until they're to the point where they can't make that decision anymore.
Do you find that patients are resistant to being identified as being at risk for dementia?
No, we've not had that experience at all. In fact, we formally tested that through our Department of Neurology, and we found that in excess of 75% were in support of this screening. They want to know. They want to know. That it was not a negative thing when they were identified as high risk and need further testing.
Outstanding. We'll wrap it up at this point.
Okay,
and,
thanks, Mark.
Thanks a lot, Chris, for stopping by and talking to us. I look forward to more information about geriatric emergency medicine. We will be putting this on the blog at epmonthly.com as well as em-blog.com. And thank you for stopping by.
Thank you, Mark. Thanks for talking to me.